failure is the most common thing which we encounter in our ICUs and wards. Around quarter to around 40% of the patients with all the cardiac illness have some form of heart failure. Let it be heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Today we'll be dealing with a case supposer who have come to us with a presentation of an acute heart failure. We know that the most common presentation of a heart failure is a acute presentation rather than a compensated stage where most of the patient come to outpatient basis. So if a patient comes to us with an acute heart failure, what are the various things we should know, what history we should take, and how to diagnose it and how to manage such cases. We'll have a brief talk on that. So heart failure is a clinical syndrome. It is characterized by typical symptoms like breathlessness, ankle swelling, fatigue that may be accompanied by signs. It is caused by a structural or a functional cardiac abnormality resulting in a reduced cardiac output or elevated cardiac pressures at rest or during the stress. So that is one important thing. It is a clinical syndrome. It is not just a disease. It is a syndrome of various manifestations. It has varied symptoms and signs, and it can be either because of the structural abnormality or a functional cardiac abnormality. Not all the patients with heart failure will have some form of structural abnormality. It can be a functional abnormality, and also it results in a reduced cardiac output. But if some cases you do not have reduced cardiac output, the cardiac pressures may be elevated either at rest or during the exercise. So it is not only at rest which is important, it is also the exercise pressures, LV filling pressures also, which are very important. So this is how we define heart failure. Before a few years, we had only two forms of heart failure, that is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. We used to call it systolic heart failure and diastolic heart failure. Now we have two more terms. One is heart failure with mid-range ejection fraction, which is also known as currently as heart failure with mildly reduced ejection fraction. So anywhere where the ejection fraction is less than 40% is heart failure with reduced ejection fraction. 40 to 49% is known as the heart failure with mildly reduced ejection fraction or a heart failure with mid-range ejection fraction. And anything which is more than or equal to 50, it is heart failure with preserved ejection fraction, also known as the diastolic heart failure. Currently, from last 1 year, there is also one entity which is known as a heart failure with recovered ejection fraction. So any patient who is in the category of heart failure with reduced or ejection fraction, if his ejection fraction improves by 10% or it becomes more than 40 to 50%, it is known as the heart failure with recovered ejection fraction. Now, why is this important is both the categories like heart failure with reduced and a mid-range ejection fraction, the management strategies are almost the same. That is the drugs like spironolactone, ACE inhibitors, ARBs, ARNIs, and beta blockers. They are commonly used in this group of drugs. However, the heart failure with preserved ejection fraction, which is seen in various diseases like atrial fibrillation, CKD, obstructive sleep apnea, chronic pulmonary diseases, those group of diseases have a different management. The disease modifying drugs do not have any mortality benefit in those groups. Only you have to give symptomatic benefit, and newer group of drugs and newer interventions are coming in the heart failure with preserved ejection fraction. However, we should also know that in the preserved ejection fraction, it is a treatment of the underlying disease, let it be diabetic, hypertension, or other valvular heart diseases, obstructive sleep apnea. So those are important. So the heart failure is actually a new onset. Acute heart failure is a new onset or a recurrence of symptoms and signs of heart failure requiring urgent or emergent therapy, which results in an unscheduled hospitalization. Basically, it refers to the rapid onset or worsening of symptoms with and without the signs of heart failure, and it is life-threatening if it doesn't undergo urgent evaluation and hospitalization. Now, we know that acute heart failure can lead to 20% of hospitalization for acute heart failure. Like the de novo are 20%, rest 80% are the chronic compensated heart failure, which because of various reasons, let it be decompensation or let it be hypertensive heart failure. So 20% are the de novo, whereas the 80% are the decompensation of a chronic compensated heart failure. Now we know that there are various causes of heart failure. I won't go into detail, but it varies from the ischemic heart disease, which is the most common, like any MI can cause any MI with mechanical complication like a ventricular septal rupture or a free wall rupture or acute mitral regurgitation, or any MI or a RVMI can cause heart failure. Then various valvular heart diseases, AR, AS, MR, MS can result in myocardial dysfunction and heart failure. Then we have various congenital heart diseases which can be associated with heart failure. We have pericardial diseases which are associated with heart failure. And then we have cardiomyopathies like the typical dilated cardiomyopathy, hypertrophic cardiomyopathy, and other forms of cardiomyopathy which are associated with heart failure. Apart from that, the rhythm disturbance like the AF, VT, and all other diseases can be associated with heart failure. So these are the way. And apart from that, acute pulmonary embolism, pulmonary artery hypertension, or various other group of diseases which can be associated with heart failure. Now, what is the underlying pathophysiology of acute heart failure is, now we can have three forms of abnormality. It can be a normal heart, it can be a heart, any trigger or any insult, like it be that is why whenever a patient comes with you with acute heart failure, there are almost 10 to 15 precipitating factors which you should always ask the history. The most common precipitating factor is the infection. What does the infection do is it causes tachycardia, and because of the tachycardia, it decreases the diastolic time, and because the diastole is reduced, the LA pressure is increases, which causes pulmonary edema. So sepsis is one thing which is the most common precipitant of an acute heart failure. Next most common precipitant is the atrial arrhythmias. Most commonly is atrial fibrillation, and other arrhythmias can also cause the triggering the heart failure. Then we should always ask the history related to the non-adherence of the medicine or non-adherence of the diet and salt or various dietary intake. Then we should always ask the history of any anemia, any pregnancy, thyroid disorders, because thyrotoxicosis can be associated with heart failure. Then we should also ask the other histories of any alcohol intake which can cause beriberi and all. Then any acute ischemic episode, chest pain and all history we should all ask, because acute ischemia can cause the decompensation of a previously underlying heart failure. We should also ask the history of acute myocarditis, and then acute pulmonary embolism can rarely decompensate a compensated heart failure. We should also ask the history of sometimes in a previously established rheumatic heart disease, any acute rheumatic fever can cause the precipitation of an heart failure. Similarly, we should also ask the history of any CVA or any subarachnoid hemorrhage or any surgical procedures which may lead to the stressors and cause heart failure precipitation, and also the history of stress cardiomyopathy which can precipitate a compensated heart failure. So after asking all this history, there are various mechanisms which can amplify the heart failure. These are the myocardial. Now what does it happen is there is a decreased cardiac output which leads to LV end diastolic pressure. Then there can be diastolic dysfunction, there can be MR, there can be tachycardia, ventricular interdependence. So these are the various things related to the myocardial which can cause the congestion. When it comes to renal mechanism, it involves because there is a heart failure and all, there is a RAS activation because there is too much of a sympathetic involvement. Renin, angiotensin, aldosterone system is involved. Acute kidney injury will be there, and there will be sodium and volume retention. When it comes to vascular mechanism, it involves the endothelial dysfunction, increased arterial stiffness, vasoconstriction, and afterload contractility mismatch. There will be a mismatch between the preload and the afterload. There will be volume redistribution, and there will be a capillary leak. In relation to the neurohormonal, there will be RAS activation, sympathetic nervous system activation, and various inflammatory and oxidative stress will be there. All this will lead to both the congestion and the end organ dysfunction. So this is the overview of the pathology which leads to the acute heart failure. Now, there are three different subsets of an acute heart failure. The most common subset is a acute decompensated heart failure. This group represents the 60 to 70% of the group, any patient who is compensated heart failure, and I told some 10 to 15 triggers. Any of this, if this leads to the decompensation, that is known as acute decompensated heart failure. Second most common, which occurs in 20 to 30%, is acute hypertensive heart failure. We know that many of the patients come to our ICU and in the emergency with BP of 200 by 100, and they will be in the heart failure, which we call is an hypertensive emergency or hypertensive urgency, or also known as accelerated hypertension. And if you do not manage the heart failure They can lead to catastrophic event like the acute pulmonary edema leading to hypoxia and cardiac arrest. The third rare event is 5 to 8% of the group acute heart failure may present with cardiogenic shock. As we all know, the definition of cardiogenic shock is important. It involves the three important points. The first is the cardiac index, which is less than 2.2, then the pulmonary capillary wedge pressure, which is more than 18, and then the third important thing is systolic blood pressure. If even after you are doing a fluid resuscitation and vasopressors and the BP doesn't rise within 30 minutes more than 90 mmHg, then this is known as the third point. And these three constitute the definition of a cardiogenic shock. Out of these three, cardiogenic shock is associated with the worst prognosis in acute heart failure. Now, as I already discussed, these are the three presentations of a classification of an acute heart failure. It can be decompensated, it can be acute hypertensive heart failure, and cardiogenic shock. The symptom onset is usually gradual in cases of decompensation. It is very sudden in case of a hypertensive heart failure. Cardiogenic shock, it can be variable. Triggers are usually in decompensation, as I already discussed, whereas in a patient with hypertensive heart failure, it is usually the hypertension and the atrial arrhythmia, which is usually more important. Then symptoms in signs in decompensated heart failure, as we already know, it can be signs of congestion, whereas in cases of cardiogenic shock, it is usually tissue height will be important, and the course is important. In a patient with decompensated, there is recurrent hospitalization if you do not stick to the underlying triggers. Whereas in hypertensive heart failure, once you treat the hypertension by diuretics and vasodilators, which are more important, it is usually treated and the mortality is usually low. Whereas the patient with cardiogenic shock is usually have a high mortality, and it usually needs something known as a mechanical assist devices like the IABP or a ECMO or Impella or a left ventricular assist device. However, it depends on the etiology of cardiogenic shock what we are dealing with. Now, most of you would have seen this table in your Harrison or in your Brownwell. We have 4 different varieties of presentation in a acute heart failure. The most common is a warm and a wet and a warm type. However, it is very rare for a patient to present with a warm and dry, and these are not actually acute heart failure. If a patient is warm and dry means there is no congestion, warm means there is no hypoperfusion, they usually present to us in OPD for the usual follow-up. However, the second class is warm and wet. Wet means the patient will have congestion, means you will get symptoms of dyspnea, you will get orthopnea, you will get PND. On examination, you will see the JVP which is raised, LVS3 will be there, pedal edema will be there, hepatomegaly and ascites may be there, and hepatojugular reflux may be raised. And it is usually a warm variety because there is no signs of tissue hypoperfusion. So this is the most common variety, which is usually managed with the IV diuretics and the vasodilators. The third variety is a cold and dry. It is dry because there is no lung congestion. It is cold and there is a tissue hypoperfusion. This is usually encountered in a patient with cardiogenic shock, and you should see the signs of decreased obtundation or mental sensorium will be low. The extremities will be cold. Patient will have oliguria. Patient will present with dizziness. There will be significant orthostatic hypotension. There will be narrow pulse pressure. So this is the typical presentation of or they will have something known as hypertensive encephalopathy type of symptoms. So this is when cold and dry is usually seen in patient with cardiogenic shock. The next is the cold and the wet. This is a very rare group. It is very difficult to see both a cold and a wet type of thing, and it is very less encountered in our ICU practice. Now, how do you evaluate a patient with acute heart failure? So the following are your focuses. You should establish a definitive diagnosis first based on your symptoms, based on your signs. We normally use a Framingham criteria. However, in clinical practice, we do not use it very frequently, because once you have a symptoms of heart failure and signs of heart failure, it is very definite that after NT-proBNP levels, which will come to it, that you have already made a diagnosis of heart failure. Second is the emergency treatment of the underlying thing like a shock or a respiratory failure, because the two things which needs the emergency treatment is a cardiogenic shock and a respiratory failure. Third thing is we have to address any triggers like any infection, any arrhythmia, acute coronary syndrome, any anemia, or all those things, any embolism, all those have to be addressed. Fourth thing is the risk stratification. Now you have to see whether you have to manage the patient in an ICU, you can manage with a smaller ICU or manage in a ward. So that level of care you have to see. And final is the clinical profile of the patient based on his underlying status, renal function, and you have to risk stratify and then decide on the final outcome. So the initial diagnosis of acute heart failure, it is based on first history, prior cardiovascular history, and any other non-cardiac problems like any infection, then any anemia, thyrotoxicosis. Then the assessment of the signs and symptom is important, and finally the other underlying the lab test, which I'll come to it. Now this is the thing which I was discussing. If a patient has a sign of congestion, he will give a history of dyspnea, orthopnea, PND. On examination, you will get a raised JVP, you will get a LVS3, you will get a pulmonary Rales, then you may have a positive hepatojugular reflux, bilateral pedal edema, hepatomegaly. All these things, signs of congestion will be there. This is a basic thing which I don't want to discuss in detail. Now the next is the right-sided congestion is usually diagnosed by a positive raised JVP with a prominent V waves and all, hepatomegaly, peripheral edema, congestive hepatopathy, and then the symptoms of gut congestion. Hypoperfusion is something which is very important to diagnose, because sometimes we may not be able to diagnose it. So clinically, how do you diagnose it? You feel a cold extremities, patient has a mental obtundation, urine out is low, the pulse pressure will be narrow. Clinically, that is one important thing where you should see the pulse pressure will be narrow in patient with hypoperfusion. And second important thing is capillary refill time. You should be able to diagnose it clinically by you're pinching the feet, fingers of the feet and all, and you'll know how much is the capillary refill time. Laboratory values, we know to diagnose hypoperfusion, we have metabolic acidosis, blood urea, nitrogen, creatinine will be increased, and serum lactate will be very high. So these are the laboratory values which they can diagnose hypoperfusion. And hypotension is important because it is important to for the to know whether the patient is having first the cardiogenic shock, and second, if you have a systolic BP of less than 90, the vasodilatory agents you may not be able to give to the patient. Bradycardia in acute heart failure is a very poor prognostic sign unless the patient is on some drugs and because of which he is having bradycardia. Otherwise, bradycardia in acute heart failure is having a very poor prognostic sign. Tachycardia, most of the patients with heart failure will have sympathetic response and do have underlying tachycardia, and managing this underlying disease and heart failure itself can reduce the tachycardia, and various drugs which we give like beta blockers or ivabradine or digoxin can help to lower the heart rate. Respiratory effort will be very high in this case. Oxygen saturation is very important because once the oxygen saturation drops because of hypoxia, you have to give immediately either oxygen or NIV or a mechanical ventilate such patient if you have some form of metabolic acidosis, PCO2 is more than 60 or a PO2 level is less than 60. So in such cases needs to be mechanically ventilated. Hypoxemia, again PO2 less than 60 mmHg or 80 mmHg is very poor prognosis, and you should immediately give NIV to such patients. Type 1 respiratory failure is far more common than type 2 respiratory failure unless the patient is having underlying respiratory disease which has decompensated a compensated heart failure. PCO2 retention is also very important in such cases. Acidosis has to be addressed. Blood lactates will be high in cases of cardiogenic shock. Oliguria represents a poor prognostic sign in such cases. Now let's discuss the management one by one. There are 4 phases. The first phase being the urgent or the emergent care. In this first, when you have a suspected heart failure, you have to first see whether the patient is in cardiogenic shock or not. If the patient is in cardiogenic shock, you have to identify the cause of a cardiogenic shock, because that is the most important thing. Your ECG may help in diagnosis. It may be helpful in diagnosing a MI, in which case you have to revascularize the vessel either with the help of an IABP or with the help of a pharmacological agents like the vasopressors and all, or inotrope. Second, if you have a AF or arrhythmias which is causing cardiogenic shock, you may have to cardiovert the patient because we know in all hemodynamically unstable patient cardiogenic shock, you have to cardiovert the patient. If suppose there is no cardiogenic shock and you have a respiratory failure, then you have to see how do you manage this patient. You may manage either only by oxygen or by a non-invasive ventilation, which can involve either a CPAP mode or a BiPAP mode, or you can do with mechanical ventilation. Patients who are not able to tolerate NIV because of severe COPD or a hypotension, or conditions like a very high PCO2 and a low CO2, in such cases you have to do a mechanical ventilation. After this, you have to see the cause of acute etiology. So there is a mnemonic known as a CHAM, which means C stands for coronary syndrome. Do a ECG, do a C for a echo. In the echo shows any wall motion abnormality, severe LV dysfunction, your troponin levels are very high, then you have to see whether it is a case of any acute myocardial infarction, which can address the issue. Then second is hypertensive emergency. If it is because of an hypertensive emergency, you can very well treat the patient with a vasodilator. This has the best prognosis out of all groups. You treat the hypertension, your heart failure will settle. Third is arrhythmia. Most common arrhythmia being the atrial fibrillation, and if the patient is relatively stable and not in cardiogenic shock, you can manage with IV amiodarone with a structural heart disease, or with the beta blockers or a digoxin. Fourth, you have to see a mechanical cause like a ventricular septal rupture, acute mitral regurgitation, or a free wall rupture. And finally, you have to see if there is any evidence of pulmonary embolism. Though the pulmonary embolism precipitating a decompensated heart failure is one of the very rare events, but you should always look for in such cases. Now, you have to start the early initiation of appropriate therapies of key importance to us. Now, what all investigations we have to do for all the patients with acute heart failure? The most important thing is the ECG. Now, why ECG is important is after the infection, the most common trigger for acute heart failure is the arrhythmia, and AF is seen in 20 to 30% of the cases. As I already told, if you have a AF, if you have a cardiogenic shock, you have to cardiovert the patient. However, if you have a AF and your patient is stable and only the heart rate is more than 150 to 60, you can use IV amiodarone or a beta blocker and a digoxin. Also, ECG is important to rule out any underlying coronary artery disease or acute MI or any ischemia. So ECG has to be done in all the patients with acute heart failure. The next important thing is echocardiography. Though echocardiography did not be done as emergency, however, if you have a suspicion that the patient had a chest pain and you are suspecting an underlying MI, for those cases, echocardiography has to be done and should be done immediately. And if you suspect that the patient has any mechanical complication based on your clinical examination, like you have a pan-systolic murmur of a VSR, or you have a systolic murmur of a MR, in all those cases, you should do a echocardiography evaluation. So, for all the de novo cases of heart failure, echocardiography has to be done. But sometimes, if it is not emergency, you can do within 48 hours from the admission too. See, this pocket size echocardiography is very helpful in patients with our ICUs. The ICUs where we do not have a standard echocardiography machine, and the pocket size echocardiography machine can rule out various things like a myocarditis, it can rule out a cardiac tamponade, or it can tell you the volume status of the patient, and you can see the IVC. Now, chest X-ray is very important, and it gives you a sign. It gives you the idea of underlying pulmonary capillary wedge pressure. We know the normal pulmonary capillary wedge pressure is less than 12. So there are three signs grading. Grade 1, 2 and 3. Grade 1 is the early cephalization of the vein, where you see the antler sign or the bat wing sign. It means your pulmonary capillary wedge pressures are between 12 to 18. When you have grade 2, that is the peribronchial cuffing, you get curly A and curly B lines, and you get something known as the peribronchial cuffing or lower zone congestion. It means you have a pulmonary capillary wedge pressure of 18 to 25. And finally, grade 3, where you have bat wing appearance or pleural effusions and all, those suggest your pulmonary capillary wedge pressure is more than 25. So grade 2 and beyond, you have to be very aggressive with your diuretic therapy, which is very important. Chest X-rays may also tell the underlying issue, something like the pleural effusion and all. So that is one important thing. The next thing which is most important is natriuretic peptide. If you are given the one test to diagnose a heart failure from a respiratory, distinguish it from a respiratory cause, that will be NT-proBNP. We know that there are various types of BNP like ANP, BNP, CNP and DNP. It is the BNP which had come out in a good way and help us to diagnose a heart failure. So before we using anti-proBNP, there was another marker known as a BNP, and they have a very high sensitivity, means they can usually rule out heart failure. A BNP level of less than 100 rules out a heart failure, whereas the anti-proBNP level less than 300 rules out a heart failure. So they have a very high sensitivity. However, we should know that the anti-proBNP value depends on the age. So in an age less than 50, if your anti-proBNP is less than 450, it is usually normal. If you have age 50 to 75, if your anti-proBNP is less than 900, it is usually taken as normal. And if your age is more than 755 and your anti-proBNP is more than less than 1350, then it is usually taken as normal. So it is usually related to age, though we say that a 300 value is a cutoff value for anti-proBNP. However, said this, you should always know that there are various other causes of anti-proBNP apart from heart failure, like in acute coronary syndrome, a high anti-proBNP correlates with the prognosis. In patients with pulmonary embolism, also anti-proBNP is associated with a poor prognosis. Myocarditis, LVH can have a higher anti-proBNP. In patients with HCM can have higher anti-proBNP. Valvular heart disease, congenital heart disease, any arrhythmias, atrial or ventricular arrhythmias. Then post-cardioversion or post-ICD shock, you can have a high anti-proBNP. Then in a patient with pulmonary artery hypertension, you can have a high anti-proBNP. However, you should know that there are other non-cardiac causes of anti-proBNP, like advanced age in patients with ischemia or subarachnoid hemorrhage. In patients with CKD or AKI also, you can have high anti-proBNP. Liver diseases or COPD can have high anti-proBNP. Anemia itself can have. However, you should remember that there are very fewer causes of lower anti-proBNP, like females and patients with obesity tends to have a lower anti-proBNP value than the normal ones. However, if you have there are some conditions which are associated with falsely low anti-proBNP, like a patient with heart failure. If you have a flash pulmonary edema, like a renal artery stenosis or something which causes a flash pulmonary edema, they tend to have near normal anti-proBNP. Patients with decompensated or end stage heart failure tend to have a lower values of anti-proBNP. Similarly, right side heart failures, you have a lower value of anti-proBNP than the left-sided heart failure. So this is something which are very important about the anti-proBNP values, and this is one investigation which you should always order to rule out a heart failure, but don't please rely on that they have a high sensitivity but a lower specificity, because there are many other conditions which they can diagnose. Now, next important thing, which is not as much as importance at cardiac anti-proBNP, is the cardiac troponins. It is a marker of underlying ischemia. So if you're based on ECG and echo, if you suspect ischemia and you have a serial rise of troponin, one value of troponin should never be given importance if you have many other things which can cause a rise troponin. However, rising value of troponin should always be given importance, and you can manage such patients with thromboprophylaxis or low molecular weight heparin and any other thing. Next important thing is ABG. Routine ABG investigation is not important in all the cases of heart failure unless the patient is in respiratory distress, where you have to see the PO2, PCO2 values and lactate levels and a pH. So that is one case where your ABG should be done. RFT, electrolyte, liver function test, thyroid. This should be done in all cases of heart failure, because most of the heart failure tend to have high blood urea, nitrogen and creatinine. And as I'll be coming to it, low systolic blood pressure, high blood urea, nitrogen and high creatinine are three adverse effects of poor prognosis in patients with heart failure. So if you have a high BUN and serum creatinine on admission, they tend to have a poor prognosis than the patients who have a lower blood urea, nitrogen and creatinine. Also, you can diagnose the underlying cardiorenal syndrome because of the poor pumping of the heart. There is low perfusion through the kidney, which can cause cardiorenal syndrome, which is associated with a poor prognosis, and that is how you can manage such cases. Liver function tests are always important because of the congestion and all, which is important. We should also do procalcitonin to rule out any infection like a gram-negative sepsis in such case, because the treatment of underlying condition is very important in all the cases of heart failure. You should always rule out thyrotoxicosis in all cases of heart failure. Now, coming to the catheterization, is catheterization necessary for all cases? No. Catheterization is routinely not done in all the cases of heart failure unless the patient is very critically ill and you need to know the pulmonary artery wedge pressure and pulmonary artery pressure so that you can manage the with the vasodilator. So only very selective cases where the patient is critically ill, you should use for an arterial line or a central venous line for pulmonary artery hemodynamic monitoring. Because most of the answers nowadays, we don't need a pulmonary capillary wedge pressure. Even a IVC can tell you the volume status, unless the patient is on positive pressure ventilation, like intubated, where they give a wrong estimation of the IVC gives a wrong estimation of your central venous pressures. Now, as I already discussed, anti-proBNP levels should be done in all the patients from heart failure to rule out other causes of heart failure like the respiratory. 12 lead ECG is a must, chest X-ray is a must, blood urea nitrogen, troponins, creatinine, complete blood count, and liver function test, and thyroid is important in all the cases. Echocardiography has to be done, if not acutely, within 48 hours of admission in all the cases with heart failure. Now, how do you risk stratify? Now you have already diagnosed your patient. Now you have to know that which is the group of the patient where I should be more careful. As I already told, there was a risk prediction score in the ADHERE registry, which was known as the CART analysis, and in that 39 variables were evaluated which tend to have a higher mortality. Out of that, there were 3 factors which were crucially associated with heart failure with poor prognosis, and they were the higher blood urea nitrogen, serum creatinine, and third was the low systolic BP at presentation. So the best predictors of the mortality were elevated burn, low blood pressure, and higher serum creatinine at admission. And this is the way where we should focus on our all patients, that if they tend to have this high value, we should give more focus on these patients. Now, after diagnosing it, we should come to the urgent, emergent care and hospital care. Now, what is more important is, first, as soon as the patient comes to the ICU, you should see whether the patient is in respiratory distress or not. Because if your patient is respiratory distress, you need either oxygen or a NIV support or a mechanical ventilation. So, monitoring SpO2 is recommended in all the patients, and the measurement of blood pH and carbon dioxide should be considered in most of the patients who are in pulmonary edema. If your saturation is less than 90% and the patient is not very ill, you can manage first with the oxygen therapy. However, if the patient cannot be managed with the oxygen therapy, non-invasive ventilation should be given either with a continuous positive airway pressure or a bilevel positive airway pressure. And you should target your PEEP to 5 to 7. And PEEP should not, in patient with COPD, you should never give a high FiO2 beyond 40 to 50%, as we already know. Now, in patients in whom NIV support is contraindicated, like patients who are mental obtundation is there, systolic blood pressure is less than 90, and you think they won't tolerate because they have significant hypoxemia and significant hypercarbia, not try to do a NIV, non-invasive ventilation, and try to do intubation, because early intubation will definitely help such cases. Now, once you are done with the acute emergency care, now you should try dividing this patient into one of these 4 groups. As I already discussed, the most you should see the presence of congestion. Now, if your patient is wet, now you clinically you'll definitely know whether your patient is wet or not, because you will have raised JVP, you will have bilateral crackles will be there, volume pedal edema will be there, and all the signs of congestion you will be able to see. If you, in that case, you have to see whether your patient is wet and warm or wet and cold. Now, wet and warm, a patient who is wet and warm, you should try to, all this patient, actually the management remains only 2 important things. One is the diuretic and second is the vasodilators. I'll come to that. A wet and warm patient, if you think that there is a hypertension, the first important thing is manage the hypertension with a vasodilator like a NTG, or a most common thing which you use is the NTG. Also, people do use nitroprusside. If you do not have a hypertension and if your congestion predominates, then it is a diuretic therapy which plays a role over the vasodilator. And unless and there are some other therapies like ultrafiltration, which is usually reserved for refractory cases. However, there are not many trials of a ultrafiltration which proves that it is very beneficial. Next, if you have if suppose you have a wet and a cold patient, if you have a wet and cold patient, this is the group which I told you is very difficult to see, both a wet and a cold, and your systolic BP is less than 90 mmHg. In all these cases, you need a inotropic agent, and under the cover of your dopamine, dobutamine or levosimendan you should use. If your blood pressure is not less than 90 mmHg, then you can very well use the vasodilators and the diuretics in such cases. Now suppose you have a dry patient and your peripheral perfusion is not good, means you're dry and cold, then always first see the IVC status. If you have a dry and cold patient, always see the IVC status. If your IVC is not congested, it is collapsed, always try it fluid challenge. You can give ringer lactate or IV fluid NS 250 to 300 ml and then see whether your BP picks up. And if your BP doesn't pick up, then you can try vasopressors like noradrenaline or dopamine and other things. However, if you have a dry patient who is also warm, dry patient who is warm, then this is the conditions which usually come to your outpatient department, and you can just manage the oral diuretics and then send them back. Now coming to the drug management, as I already told you, diuretic remains recommended for all the patients with heart failure with signs of fluid. Articles which have come which tells that unless the patient has volume overload, signs and symptoms, you should not try to give diuretic. So only in the patient who has signs and symptoms diuretic. Now before, our practice was to give continuous subcutaneous diuretics, like we used to give loop diuretics IV 20 to 20 mg for 40 20 mg 4th hourly, 6th hourly or 8th hourly. Now the recent practice, what they say is you should not continue to 60 mm of milligram, and then you have to reassess the patient after 6 to 8 hours. Now after 6 to 8 hours, if you think that the patient is doing good, then there is no need of further diuretics. If you think that the patient is still volume overloaded, you can again repeat a similar dose of 40 to 60 milligram of loop diuretic. So the current recommendation is holds on patient diuretic throughout. Symptomatic, whether they also such patients should use sodium on during sodium, you should try to do a diuretic based on whether their weight is coming down or not. So IV diuretic, mainly the loop diuretics for therapy in all the patients who have fluid retention and fluid overload. Now, in patients with new onset acute heart failure and those with chronic decompensated heart failure not receiving oral diuretic, as I already given 20 to 40 milligram or can be little higher. However, if the patient is suppose some patient is on most, what we have to do is change the oral form to 40 milligram BD of IV. Many of us, what we try to do is we change to 160 milligram, which is very high dose. I will try changing to the same dose of IV diuretics what the patient was on the oral. However, if the patient is not on any oral drugs for few days before admission, you should just give 40 milligram and reassess the patient after few hours. Also, it is recommended to give diuretics either as intermittent bolus or as a continuous infusion, which is not a very recommended treatment. And suppose if the patient has diuretic resistance, there are many patients who have diuretic resistance either because there is something known as the breaking phenomenon. In breaking phenomenon, what happens because of the diuretic, all the extracellular fluid is washed off from the body that activate the renin-angiotensin system. When the renin-angiotensin system is activated, again this leads to the fluid reabsorption. So that is known as the breaking phenomena, which is one of the important mechanism of a diuretic resistance. They also tend to have hyperaldosteronism, that is another mechanism of diuretic resistance. Also, there is a hyperplasia and hypertrophy of the epithelial cell in the distal collecting tubule, which may be causing the diuretic resistance. So any patient who has a diuretic resistance should be managed in a different way. Like you have to combine the two different classes of drug. Like a loop diuretics, you have to combine either with a metolazone. We know that the drugs like metolazone are very frequently used in heart failure, and one of the reasons why they are used is diuretic resistance. So you can use a loop diuretic with the most commonly metolazone. You can use with a thiazide type of diuretic. Also, to break the hyperaldosteronism, all the patients should be managed with spironolactone or any other from like the eplerenone, because hyperaldosteronism is one of the important mechanism. So spironolactone is not only used for decreasing the mortality in heart failure, it is also used to prevent the diuretic resistance. So that is one important thing which we should also consider. So after the diuretic, the second most important drug which is used is vasodilator. So vasodilator, the most common drug which we use is NTG, and we can also use drugs like the sodium nitroprusside, which have nitroprusside. Now we should not use vasodilator. The most common group where we use vasodilator is the acute hypertensive heart failure. So any patient who comes to your ICU with BP more than 140 or 150, you should first try to start them on IV NTG and not manage with the diuretics, because the IV vasodilator remains the first choice of drug. Even in patients with acute decompensated heart failure, unless the BP is less than 90, you should always try to manage such patient with a vasodilator if the BP is more than 90. 90 remains a very low cutoff, we know, but most of the trials show that if the BP is more than 90, you can very well start the vasodilators in such cases. And in patients with hypertensive heart failure, vasodilators should be considered the initial therapy. Now, when do you give your drugs like inotropic agent, dopamine, dobutamine, and levosimendan? Now, inotropic agent IV infusion should be considered in patients with hypotension and signs of hypoperfusion. As I already discussed you, patients who are cold, patients who are not wet but who are dry and cold. So this is the group of patients which need the inotropic agent, because they have hypoperfusion. The organs are not receiving enough blood. So to increase the myocardial contractility, which we give drugs like dobutamine, dopamine, and levosimendan, and other drugs like milrinone, which is not very commonly available in our ICU. For the practical purposes, I just want to tell the levosimendan is currently at present not available in our country, and it is for some reason it has been removed from the market. So the only drug which is available at present is dobutamine, which we have to use very liberally in such cases. Also, levosimendan was being used as a very efficient drug compared to dobutamine, because though the chances of atrial fibrillation was more, the chances of hypotension was less as compared to dobutamine in levosimendan, though the rates of atrial fibrillation was more. Also, if the patient who was already on beta blocker, suppose if the patient who was on beta blocker, if you have to give the drug, you should use levosimendan and not the dobutamine in such cases. In cases of CKD, established CKD, you cannot use levosimendan, you have to use dobutamine. However, if the patient has cardiorenal syndrome, like a acute heart dysfunction is causing the renal impairment, then levosimendan can be used. So these are the few things which is important. However, if the patient is already on beta blocker, to reverse the effect of beta blocker, levosimendan is being a good drug. So unless the patient is symptomatically hypotensive or hypoperfused, you should not use the dobutamine, levosimendan, or milrinone. Now, what is the role of? Now we know that after many trials like the SOAP2 and SOAP3 trials which have come, the best vasopressor at present is the norepinephrine, which is better than dopamine, because dopamine has few other side effects like the arrhythmias and all, which is less with compared to noradrenaline. So noradrenaline may be considered in patients who have refractory cardiogenic shock. Now suppose you have given dobutamine to some patient or dobutamine to some patient, and the patient is still hypotensive, or if you are given a fluid resuscitation to some patient and the patient is still hypotensive, the first choice of drug will be a noradrenaline to increase the blood pressure and increase the vital organ perfusion. And all that, you should try to use all this drug via the central venous line, and then you should always monitor using ECG whether they can have arrhythmia, they can have myocardial ischemia, and also the levosimendan, which can cause hypotension. And you should always see that if there is any underlying cause which can cause hypotension, you should use intra-arterial blood pressure, IABP, in all such cases. Thromboprophylaxis should be used in cases of underlying ischemia if it is there, and if the patient is bedridden, then you should use low molecular weight heparin in all such cases. Now, what is the role of other drugs? The other drugs like digoxin and beta blocker. As I already told, beta blocker is an important part of heart failure. But if some patient who is on beta blocker and who comes with cardiogenic shock, you should not use beta blocker. You have to stop beta blocker. However, this is not true for all the patients who present with heart failure. Suppose a patient presents with acute decompensated heart failure or a hypertensive heart failure, and the patient was on beta blocker, try not to reduce his beta blocker, stop his beta blocker. Maximum what you can do is you can reduce the dose of beta blocker to the half, because sudden stoppage of beta blocker in such case can lead to either ischemia or it can precipitate arrhythmias. So that it is very risky. So unless the patient comes in cardiogenic shock, try not to stop the beta blocker, just reduce the dose of beta blocker to the half. Digoxin has been tried in cases of heart failure if the patient has heart failure with AF. Unless the patient is in AF or heart failure, it is not considered a very good drug, though people do use it in refractory cardiogenic shock or biventricular dysfunction, and if you are not able to give any other drugs, then digoxin can be a good drug. Amiodarone can be used to control the rate if the patient is not in cardiogenic shock. It is best used for rhythm control for converting the rhythm to normal in such cases. Opioids like morphine and all should be used with precaution because they can cause respiratory depression. However, morphine has been tried to reduce the preload and can be used to relieve pulmonary edema and can reduce the anxiety also in such cases. Now, I won't go into detail in this slide because I have already told most of this thing. Diuretic should be one important thing. Is diuretic does not only has increased renal water excretion, means the water clearance is not only increased, it has some vasodilatory effect because of the prostaglandins also. If the patient has only hypertensive heart failure, that cases try to avoid diuretics, try only vasodilator. Only if the patient has volume overload status, then you should give diuretics. The first important thing is you have to use loop diuretics. Both the loop diuretics and the thiazide like diuretics, as the creatinine clearance increases, their efficacy decreases. So you should always try to use a higher dose of diuretic in such cases. Thiazide diuretics should be used with caution when the creat clearance go less than 40, and in such cases only a loop diuretic should be used. And diuretic resistance, as I already told, you can try by managing with 2 to 3 group of drugs like a loop plus a thiazide or a loop plus a spironolactone, or you can so those are the common things. Natriuretic, next important is as I already told you, there is no difference between the high dose arm of the dose study. In the dose study, the high dose arm, where the 2.5 times of the previous oral dose was used of it, means many a time what we do is patient is receiving IV oral diuretic 40 milligram PD, we try to convert it to 40 into 2.5. So that doesn't have much benefit. It just resulted in a greater improvement in dyspnea and a weight change and fluid loss. However, the renal functions were worsening much higher than this. So as I already discussed, if the patient has volume overload status, give a 40 milligram, reassess after 6 to 8 hours. If the patient is okay, then no need of further diuretic. If the patient is still in volume overload, you can repeat a 20 to 40 milligram bolus till the patient is okay. And apart from the loop diuretic like furosemide, the drugs like torsemide and bumetanide, which have a higher bioavailability, for furosemide has a bioavailability around 60 to 70, whereas a torsemide has a bioavailability of around 80%. Those drugs can be used as an alternative in such. Many people do use infusion of diuretic. Though there is no much benefit of infusion, the rise in creatinine is lesser as compared to the IV boluses. So, however, the dose trial which was done with infusion versus IV boluses, there was no significant difference between the two. However, we do use infusion of Lasix when the patient is actually in a borderline stage of blood pressure, and still you have to use the drug. So if you give the infusion, the drug concentration remains longer. So the concentration in the blood is longer, and then so it can be used. Now the next group of drug is a vasodilator drug. As I already told you, the most common scenario where you should use it is a hypertensive heart failure. You should not use it when the patient BP is less than 90 mmHg. The most common used drug is a nitroglycerin. We know that you have to start the dose at 10 to 20 microgram per minute, and maximum you can go up to 200 micrograms. Some people can go up to 400, but that is not the dose which we use. You can go from 20 to 200 micrograms. Always remember, try not using it beyond 48 hours, because the NTG can lead to tolerance. People can have side effect with NTG like hypotension and headache, which can be managed symptomatically. But also remember that the NTG, because of the sulfhydryl ions, causes tolerance in the long run. So not 48 hours, better to avoid NTG. One more important drug which people use is nitroprusside. The nitroprusside is also one drug which is people are using. Always remember, the nitroprusside should never be used in patient with acute MI. In a patient with acute MI, you should not use it for controlling the heart failure, because it can dilate the coronary vessels. It can cause vasodilatation, and there can be significant steel effect which can be harmful. Nitroprusside also tend to cause a similar side effect as NTG. However, there is one thing which is cyanide toxicity. It has cyanide ions and it can cause isocyanate toxicity. Though it is rare, it can happen. So because of its safety profiles and other things, we use the nitroglycerin, which is more commoner than the nitroprusside. Another drug which few people use is a nesiritide. Nesiritide, we know, is though available, we do not use much, but it is used in some parts. Now, next, coming to the inodrops, as I already discussed, the most common inodrop which we use is a dopamine. Now, dopamine has three actions. At a dose 1 to 2, means less than 2 microgram per kg per minute, then at a dose of 3 to 5, and at a dose of more than 5. At a dose of less than 2, it is used as a vasodilatation of the splanchnic vessel and the renal vessel, and it causes increased urine output. However, 3 to 5, it acts on the beta-1 agonist. It has beta-1 action and it causes the inotropy. So at 3 to 5 microgram per kg per minute, it has inotropic action. As you go beyond 5, there is extra alpha agonist action, and because of which it causes the vasopressor effect, and you can have myocardial ischemia, renal ischemia, peripheral ischemia, and also beyond 5, dopamine is a little risky. You should use it less than 2 or 3 to 5 microgram per kg per minute. Now, the next drug which is very important is dobutamine. Dobutamine has a predominant effect of beta-1 more than beta-2. So because of its effect on beta-1, it causes the inotropy. It can have side effects like the arrhythmias and hypotension. Hypotension is less common with levosimendan, but the arrhythmias are more common with levosimendan compared to dobutamine. However, if the patient has organ hypoperfusion, dobutamine at present remains the drug of choice. Also available was the levosimendan, which is not available at present. I already discussed levosimendan should be used in patients who are previously on beta blocker, should not be used in CKD, where dobutamine is the first drug of choice. Also, levosimendan can be used in cardiorenal syndrome, not CKD, but the cardiorenal syndrome. Few drugs like a milrinone, which is an inodilator, as I discussed. Milrinone has a phosphodiesterase 3 inhibitor. It has both the inotropic part and the vasodilatory part. So milrinone needs to be given as a bolus followed by the infusion. Drugs like inoximone are not currently available, and we do not use it much frequently. So after the inotropic factor, the drug like vasopressors, which I already told you, noradrenaline is the drug of choice, should be given. And And apart from that, epinephrine, which norepinephrine was tried in SOAP 2 and SOAP 3 trials, where it showed that as compared to the dopamine, it has a very much better and less ischemia, myocardial ischemia, less high and less side effects compared to the dopamine. Epinephrine is only reserved for patients who have undergone CPR and during resuscitation. Also, post cardiac transplant patient, epinephrine is a good drug to be used, but not otherwise. Or a refractory shock where any drug has to be used, then in those cases, epinephrine and vasopressin can be used. So, as I already discussed, dopamine was compared with the norepinephrine. norepinephrine had fewer side effects and lower mortality. So that is the take-home message of the one drug which you have to use in a patient with hypotension, not refractory to inotrope and refractory to fluid challenges, norepinephrine. Epinephrine should be restricted to patient with persistent hypotension and the use of other vasoactive agent, as well as only in resuscitation protocol. Now, what drug you should not use in a patient with heart failure? That is one important question. Which drugs should not be used? So pioglitazone group of drugs which cause volume overload should not be used. NSAIDs, which causes again volume overload, should not be used. Diltiazem and verapamil should not be used. Amlodipine also is one drug which should not be used in patient with LV dysfunction. Also, you should not combine ACE and ARB together in any group of patients. Some people say that ACE ARB with the spironolactone should not be used because the risk of hyperkalemia and renal dysfunction is used, but most of the time we tend to use ACE ARB because of the cardiac protective thing. Now, as I already discussed, thromboprophylaxis should be used if you are considering any ischemia, any underlying ischemia. Digoxin is mostly indicated if the patient has fast ventricular rate. Many people use IV boluses of 0.25 milligram. However, it should not be given more than 5 days a week because of the half-life is around 120 hours. So you should avoid at least digoxin-free intervals. Opiates, as I already told, it relieves the anxiety and dyspnea. Routinely, we should not use unless the patient is very severe in distress and you have to intubate the patient and keep him calm. Now, there are some group of drugs which are apart from this used in acute heart failure. Like suppose if the patient has significant either hypervolumic heart failure or euvolumic heart failure, and if the patient has hyponatremia, in such cases vasopressin antagonist like a selective agents like a tolvaptan, which is a V2 receptor selective antagonist, is used. So tolvaptan blocks the V2 receptor in renal tubule and it promotes the diuresis also. So it is used to treat patients with euvolumic or hypervolumic hyponatremia, even a resistant hyponatremia. So tolvaptan is one drug which have been used. Now, what is the role of renal replacement therapy? Now, there are two groups, two thoughts. One is ultrafiltration. So as I discussed, there is no role of ultrafiltration. There were few trials which had come for the role of ultrafiltration or loop diuretic. However, apart from removing the weight, decreasing the weight and volume, it did not have much effect on neither the mortality and their renal worsening has been worsening of the renal failure were more with the ultrafiltration. So currently we do not advocate the use of ultrafiltration. However, renal replacement therapy like a dialysis should be indicated if you have an oliguria which is not responsive to fluid, not responsive to vasopressor, severe hyperkalemia, metabolic acidosis, your urea levels are very high and the creatinine is very high. So those are the indications of renal replacement therapy in acute heart failure. Now, what is the role of devices like mechanical assist devices? I already told you, unless needed, the IABP, that is the intra-aortic balloon pump, should not be used. So which are the groups where it is used? Is most commonly is cardiogenic shock. If you think the cause of heart failure is MI, like acute anterior wall MI with heart failure, or a posterior wall MI with pulmonary edema, or a mechanical complication like the ventricular septal rupture, free wall rupture, or a MR, papillary muscle rupture causing MR, those are the cases where IABP is truly needed. However, there are cases like a peripartum cardiomyopathy or a myocarditis, patient is having myocarditis. Those are the cases where we should not use the IABP. Third important thing is when you are doing a revascularization in a very complex cases, such are the cases where IABP can be used. However, the current recommendation says that there is no good evidence of the use of IABP in patients with cardiogenic shock or any heart failure. Now, the next important thing which came was the use of extracorporeal membrane oxygenation. So this is one thing which is very useful in patients who are having cardiogenic shock or patients with pulmonary edema. We have something known as the ECMO, that is extracorporeal membrane oxygenation, and this definitely helps. There is a benefit of these devices in patients with refractory cardiogenic shock. Now, ECMO, what it does, it is used as a bridge. It is used as a bridge to destination. That is, if it can be used as a bridge to some patient may be put on LVAD devices, some patient may be used as a bridge to transplant or a bridge to destination. ECMO can be used as just a sole treatment, and then you can remove the ECMO. You should not use ideally beyond 14 to 21 days. So these are the few things where ECMO can be used. Now, there is after that one more new classification of cardiogenic shock. where A, B, C, D, E they had divided. A stands for at risk for cardiogenic shock, B is borderline cardiogenic shock, C is proper cardiogenic shock, D is deteriorating, and E is end stage. So this is one more classification. I think it's not much important. You should know what is the definition of cardiogenic shock. If the cardiac index is less than 2.1, capillary wedge pressure is more than 18, and your systolic BP is less than 90 despite your vasopressors and inotropes, so then it is called as a cardiogenic shock. Now there are few other drugs which I have not discussed, which are not in the guidelines. People are using one of the drugs which have come recently in acute heart failure is cyclic guanyl cyclase stimulator, that is the vericiguat. We know that riociguat was one drug which has been used in pulmonary artery hypertension. It is a phosphodiesterase inhibitor. It is a cyclic guanyl cyclase stimulator. Similarly, vericiguat is a drug which has been come for acute heart failure, and it is an oral drug. Apart from that, there is some other drug like the myosin kinase activator, which is omnacative. That is one drug which has come, but those drugs have not yet come to the guidelines. So those are the very rare drugs which we should just remember the name. Now, once you manage the acute heart failure, what is the hospital care? We know once the patient is moved to ward, there are a few things which you should see daily. You should see daily the patient hemodynamic status, BP. You should see the urine output. You should see the daily weight. The daily weight is important. Volume status is important. Also, you should see if there is any signs of orthostatic hypertension which should be avoided in such patient. So daily fluid intake and output is important, daily weight is important, orthostatic BP is important. Laboratory parameters are important because we know that the blood urea, nitrogen and creatinine are very important, and you should try to maintain such things. So the fluid restriction should be ideally based on the urine sodium excretion, ideally, but overall we should try to restrict to less than 1.5 liters and the salt restriction to less than 2 grams per day. Patients who are on beta blocker, we know that they should not stop being beta blocker, as I already told. So patient on beta blocker, you can reduce the dose of beta blocker to the half, but should not stop it because the rebound phenomena can cause more serious issues than serious issues. And then you have to treat the underlying targets, like you should see whether the patient is a candidate for cardiac resynchronization therapy. I told you, if the patient, this you'll be knowing that the patient has underlying LBBB, that the QRS duration is more than 150, and if the patient is already on all drugs and the heart ejection fraction is less than 35%, then you should consider such cases for cardiac resynchronization therapy. So these are the important things. All the comorbidities should be told to the patient, self-adjustment of diuretics should be told to the patient, daily weight should be told, exercise programs should be told, cardiac rehabilitation should be done, nutritional counseling should be done, cessation of smoking, cessation of alcohol should be done. Now, pre-discharge planning is something is important. All the patients should be on all the heart failure disease modifying drugs like the beta blockers, spironolactone, ACE inhibitor or the ARB. There is one group of drug which is also used is angiotensin receptor neprylation inhibitor, that is the sacubitril valsartan. Though they tell when the patient is just recovered from acute decompensated heart failure, we should not try to initiate drugs. This has not come in the guidelines. However, few trials do say that after recovery from acute decompensated heart failure, if the BP is more than 90, you can try initiating, but it is risky. You should try to start it in a compensated setting, not in a decompensated setting. Patients whose blood pressure, heart rate continues to be more than 70 to 80, we should always try to give ivabradine to reduce their heart rate, because a good heart rate control also tries to decrease the incidence in hospitalization for heart failure. We should try avoiding drugs like NSAIDs. We should try avoiding pioglitazones. One more drug which has come in patients with heart failure in reduced ejection fraction is dapagliflozin. As we all know, the DAPA really coming up in patients with heart failure who are diabetics and patients who are not even diabetics. So the patient should be on beta blocker, ACE inhibitor or ARBs. Patient should be on a spironolactone, and then the patient should be on some diuretics as per the requirement of IV diuretics. Now, what is before discharge? What all we should see is all the exacerbating factors are addressed, like the infection should be controlled, atrial fibrillation should be controlled, anemia should be corrected, thyroid issues should be corrected, and all other if any ischemia is there, it should be addressed. volume status, optimal volume status should be observed. We should try to change from the IV to the oral fully family education, cessation of smoking, cessation of alcohol, everything. Pre-discharge LV ejection fraction should be documented, and the patient should be on optimum therapy with the ACE inhibitor and the beta blocker. The first follow-up visit should always be done after 7 to 10 days after the discharge. And before discharge, you should always know that the patient should be on oral diuretic for at least 24 hours and no IV vasodilatory agents or inotropic agents for at least 24 hours. He or she should be ambulatory pre-discharge, and exercise rehabilitation should be started in all patients. And you should tell them to on a telephonic visit if they can tell their weight and all other things. And if any other issues are there, you should try to manage that. And the first review should be 7 to 10 days after the discharge. And one more thing which I always also like to address is the vaccination. Any patient who is having heart failure, age more than 65 years, you should always try to give them pneumococcal and Haemophilus influenza vaccination, because they tend to have a higher incidence of heart failure. Also, one important thing to be addressed is the iron therapy in heart failure. Patients who have recurrent hospitalization for heart failure, if their hemoglobin is less than 15, then you should see something known as the ferritin and the transferrin saturation. If your ferritin is less than 100, or your ferritin is between 100 to 200 with a transferrin saturation of less than 20, all the patient ideally should receive iron carboxy maltose of at least 500 to 1.5 gram depending on their weight. So that is one thing which is actually coming up in patients with heart failure to reduce their hospitalization and increase the functional capacity, like the 6-minute walk test.